Jim Keenan. I'm the Vice Provost for Global Engagement. And this is our inaugural lecture of the Global Scholars Lecture Series. So we're very happy that Sarah Jensen has agreed to be our inaugural speaker. She is a research scientist working with Professor Teresa Betancourt at the Research Program on Children and Adversity at Boston College School of Social Work. Her research seeks to delineate the role of early psychosocial and biological experiences in shaping children's cognitive, emotional, and neurological outcomes. Furthermore, she uses the knowledge to guide the development of interventions to prevent adverse outcomes among children facing various forms of adversity. She has a degree in clinical psychology from the University of Copenhagen and completed her PhD in development psychopathology at King's College London, where she trained in neuroscience and explored associations of early life stress and poor parental mental health with children's cognitive, neuroanatomical, and emotional outcomes. In her 2 postdocs, she transferred her interest in early adversity research to the field of global child development research and has worked on studies of children growing up in severe poverty in contexts such as Bangladesh and Rwanda. Her current work focuses on coaching-based parenting intervention to promote healthy child development and prevent violence in families facing severe poverty in Rwanda, work that we will hear much more about in her presentation. Sarah will be presenting for about 40 minutes, and then we'll have about 20 minutes for questions, Q&A at the end of it. And her presentation is entitled Promoting a Child Development in Settings of Severe Adversity. Thank you.
Thank you. So yeah, thank you for the invitation to speak today. It's really nice to, be giving a presentation in person, not on Zoom. That's very exciting for me. And I'm excited to connect with this group of people. First of all, as you just heard, I do global work, so I very much am familiar with the Office of Global Engagement. And as an international student, coming originally from Denmark, but having lived abroad for quite a while now, and thank you for the very correct pronunciation of my name. I appreciate that. I obviously also know the Office of International Students quite well. So it's exciting to be part of both groups and sort of celebrate that here. Because this is a longish presentation, about 40 minutes is what I aim for the actual presentation and then questions. I just wanted to give you a brief outline of what to expect. So first I'll be giving some theoretical introduction to where all of my interest in global early child development is coming from, why I think it's important, what are some of the key themes. I figured that maybe not everyone in this audience is familiar with global child development as a research discipline. And then I'll be focusing most of the talk on our work in Rwanda. So that is work that I'm currently engaged in with Professor Teresa Betancourt in the research program on children and adversity here at the School of Social Work at Boston College. So I like to start with this figure because I think it's very important for understanding where we're coming from when we're studying early child development and how early child development is influenced by their environment. So it's an old figure by now. It's from the late 1970s, and I don't expect that this is like a novel content to any of you in this room, really. But it's a reminder that children's development is situated within and critically depend upon both a social and a more contextual environment. So it reminds us that children are influenced both by their proximal environment, which is often referred to as the home environment, or their caregiver, who they depend on to meet not just their critical basic needs like nutrition and warmth, but also stimulation, care, stability, and this safe environment from which they can explore the world and learn and engage in social interactions and play that helps them develop cognitive skills, social emotional regulation, and all of these critical skills to thrive in a world. And because the child is so critically dependent on the caregiver, characteristics of the caregiver obviously also become very critical in determining how the child's conditions for thriving early in life are. and things like the caregiver's psychological resources, education, and stress really affect their ability to engage in these social interactions and to provide this stable environment that children need. And the caregiver's socio-emotional resources and psychological resources then in turn depend on a more distal environment that is impacted by the community they live in, the level of psychosocial support that they receive from this community, poverty, and all of these kinds of things. So all of these things come together in this multi-layered structure to really affect children's development. And the better we understand this model, the better we understand how each of these different factors contribute to children's development, the better we'll be at supporting children in developing and reach their best potential. So there are certain gaps in child development that translate into long-term poor outcomes for children. So children who don't have the optimal conditions to thrive early in life because of risk factors in their social environment or their more distal environment tend to fall behind on cognitive, linguistic, and socio-emotional outcomes. And there's a large literature to show these socioeconomic gaps in children's outcome in terms of their cognitive development, their linguistic development, and their school performance. There's also a large literature from the global world looking at stunted development and how children who are stunted tend to enter a grade later in school, perform more poorly in school, repeat grades, drop out of school before they complete primary school, experience poor physical health outcomes and mental health outcomes, engage in high-risk behaviors and become less productive and have lower earnings throughout life. Here's a figure from a very important paper that I'll discuss more later on that really demonstrates this widening wealth gap in children's vocabulary, which is just one domain of child outcomes. So you see the different colored graphs here demonstrate different quartiles of children based on their wealth. And you really see how at the first data point you see is age 3, and you see how they start off pretty equal in terms of their performance and vocabulary. But over development, this gap really widens. And at the age of, it says 66 months, we have this really wide gap whereby children who are in the highest quartile perform at about at level with populations, so this is a standardized score. So a score of 100 means that children perform similarly to children in high-income countries, but this is a sample of children from Ecuador. And children who are from the lower socioeconomic groups have fallen behind greatly. And you see that children in especially the 2 lowest quartile really have fallen far behind and score around 50, a score of around 50 on this standardized score, which is a huge gap in terms of development. As I mentioned before, another widely studied, aside from poverty being a central risk factor that threatens child development in low-income countries, stunting is another widely studied risk factor that's common in settings of poverty and in low and middle-income countries. And stunting is generally considered a result of long-term undernutrition. And here I have a model to show different kinds of anthropometric outcomes that are studied in the global child development literature. And stunting is when a child is lower than would be expected for their age. And that's what this figure is showing. And then there are other things that we also look at, which are things like underweight, which is that they weigh less than what is expected for their age. Or wasting, which is that they weigh less than is expected for their height. Stunting has really been the focus as a risk factor or indicator of a child being at risk of poor development because of its association with this long-term undernutrition, which has an impact on their neural development, as well as other pathways like reduced energy and reduced physical ability to engage in educational activities and in interactions with other people. So stunting has been determined or sort of conceptualized as one indicator of a child's risk status outside of poverty. And one of the really dominant publications that casts light on both poverty and stunting as risk factors for child development was this publication, which is, it was published in 2007, and then later repeated in 2017, so they're now working on a new series. But it's part of a series on global child development that was published in the Lancet. And the 3 papers that came out with this series, and again, the 3 papers that came out 10 years later are really worth reading if you're at all interested in global child development. But a key figure that emerged from this paper, and also was updated later on, was this finding that over 200 million children in low and middle income countries who were under the age of 5 years are at risk of poor or of not fulfilling their developmental potential because they are either exposed to poverty, so at risk of experiences this wealth gap, or the wealth gap that translates to poor cognitive outcomes, or because they're stunted, which, as I said, is also associated with these poor outcomes in children. They estimated the figure again in 2017, where they defined the figure to be 249 million children who are at risk, or 43% of the population of children in low and middle income countries. And I think this regional map, or this world map with regional trends, is very important because it really demonstrates where children at risk live more, where the risk is most concentrated. And you see, obviously, that the highest burden is observed in sub-Saharan Africa, but also in Southeast Asia, where on this map, different color codes mean the level of risk in percent of children, or of the children who are at risk of poor development because they're either poor or stunted. And I realize that you probably can't see the numbers. So 60%, the orange color means that 60% of children who live in this region are at risk of poor development, whereas the green color means 40 to 59%, and then the blue color is 20 to 39%, and the yellow color means lower risk, and white color means no data. So as part of this series, they also proposed this mechanistic model which summarizes what I've just been talking about, which is the definition of poverty and stunting as key risk factors for poor child development. And it also highlights that these factors don't just work in isolation, but they really influence children's development through this social environment, this proximal environment that was demonstrated in the very first figure I showed. And this is important because it highlights a potential avenue for intervention, which is it's really hard, although important to try to do to prevent stunting and poverty in the first place, but that requires really big systemic changes to turn around, whereas parenting interventions to support care for children and home stimulation is a more feasible target if we want to improve the developmental potential of children who live in these at-risk areas of the world. There have also been other risk factors that have been explored in the context of early child development in global settings. And this figure is showing some trends in topics that have been covered or risk factors that have been explored. And you see an increase in the number of publications that have looked at stimulation in the home as a factor that influences children's development. Micronutrients also increasingly explored outside of just stunting, which is used as a proxy for development. It's not a direct association between stunting and cognitive function. It depends on all kinds of processes, including neural development. So micronutrients gives a more fine-grained picture of what the association really is. Breastfeeding, maternal education, child abuse, malaria, and maternal depressions are some of the topics that we've seen increased attention to, also in global child development literature. Another concept that is discussed a lot in this literature is like, when can we do something about these poor outcomes in children? And there's this concept of the first 1,000 days that comes up a lot in the literature on early child development. And to me, it means two different things, or it relates to two different findings, although the very widely cited figure of the first 1,000 days really is used both in the nutritional and the more child development focused literature. In terms of nutrition, it means that children who are stunted before they turn 2, and if you don't turn that around and help the children gain weight before then or gain height, then it's really hard to turn that trend around later on. But it also refers to the sensitive period in neurodevelopment, which is that the majority of the brain's development really occurs within the first 1,000 days, or the first 2 years of life, so 2 years of postnatal life, and the in utero development of the brain. And here are just some examples of the rapid growth that we see in the first 2 years of life in the brain, from the newborn brain seen right here with very few synapses to a 2-year fully fleshed brain with lots of connection between the different regions. And this other figure over here demonstrates, and again, it's really hard for you to see in the room, it demonstrates these different periods of sensitivity as referring to different the rate of brain development in different regions of the brain. So these different lines or charts demonstrate different senses. So the green one is seeing and hearing, then there's language, and then there's higher cognitive functioning. And we see that they peak at different times between, here we have birth, and here we have 2 years of life. But all the peaks occur within these first 2 years, which means that because we see all of this synapse formation in the brain, it's really important that we make sure, because synapses form when a brain is stimulated, when a child is exposed to stimulating activities, it's very important that we make sure that children are exposed to these stimulating events and activities early in life to secure this optimal brain development. So I just wanted to quickly show you an example of some work that I did in my first postdoc at Boston Children's Hospital with Chuck Nelson, where we worked on a research project also in a global setting in Dhaka in Bangladesh, in an urban slum. I'm showing some pictures here of the kinds of home environments that these children lived in. And I'm showing a graph of the standardized cognitive scores of children living in these impoverished environments. And the data comes from two different cohorts that were assessed at 2 different time points. So the first cohort was assessed, that's the blue, the 2 blue charts, and they were assessed at 6 months and around 2 years. And then the second cohort was assessed at 3 years and 5 years. And what this demonstrates is that in the first cohort, the green line shows you the standardized score. Again, it's standardized to 100. So children who fall around the green line have the expected score in this cognitive test, and children who fall above have above average scores, whereas children who fall below the green line have below average scores. And we see this clear trend. You also see a great line in the middle, which shows the normal range. And we see that early on in development, in the first 6 months of, or in the 6-month-olds, we see that most of the children fall within this expected range, and if anything, they perform above average on this test. But from age 2 and onwards, they've really fallen behind in terms of their cognitive performance. So this confirms this idea that something happens between the first 6 months and 2 years, whereby children can really fall behind if they don't have the optimal environment to thrive. And in this paper, or in this cohort, we also looked at different predictors of or associations between poverty and the child outcomes, confirmed that there is an association, and tried to explain what different risk factors might drive this association. And we looked at things like the child's growth as a mediator of the outcome, the child outcome, family care and stimulation and inflammation, and find that all of these things mediate some of the association between children's poverty status and their cognitive outcome. And we see this across the different cohorts with the 6-month-old, the 2-year-old, the 3-year-old, and the 5-year-olds, where I realized you can't see the different outcomes, but we looked at things like these different outcomes represent language outcomes, motor outcomes, cognitive reasoning. And it's not very important that you understand the exact association. The main point that I want to make here is that all of these different factors, both the social environment and the biological environment of the child, predicts some of the effect of growing up in poverty, or mediate some of the effect of growing up in poverty on the child's general developmental outcomes. And it really tells us that for interventions to be effective, we need to address a lot of different risk factors. It's not like a one-fit-all. Only providing children with nutrients or only providing them with stimulation will not fix the whole developmental gap that we're observing in children in severe poverty. And this now brings me to the research in Rwanda. So in Rwanda, the research program on children and adversity has an ongoing research study called the Seguro-Moyango Intervention Study. Seguro-Moyango means strong families, and it's a parenting intervention that seeks to help children develop through working with families and parents to provide parents with the resources and skills and coaching to create this optimal environment for the child. And I'll talk more about the intervention, but first I'll just give a little bit of a brief background to Rwanda. So Rwanda is a low-income country with a very ambitious poverty reduction strategy, which includes a focus on early child development initiatives. They have a national early childhood development program that coordinates different interventions to support early child development that include government employees that are trained in social protection and child development. They built ECD centers for children who were over 5 years of age so they can attend early childhood education services. And they have seen some really great results in terms of lowering maternal and child mortality and increasing access to early child development services for these older children. And they have strong governance and a lot of will to support children and vulnerable families, which is great. But there are still some very important barriers in Rwanda before they really can reach their goal of poverty reduction and improved child development. They continue to struggle with high rates of poverty. 39% of the population is poor, and they have high rates of childhood stunting. On average, the national average of stunting is 37% of children are stunted. And then they have poor access to to child educational services for children who are under 5 years, high rates of violent discipline and intimate partner violence. And here I just show this graph of the problem of stunting as it increases over age. So you see stunting is the blue line. And you see how it starts off being not so frequent at around 15–20%, but by the time children are 2 years of age, it's about 40% of the children in Rwanda who are stunted. I also wanted to bring up some other background information that provided input for the development of the Seguro-Moyango intervention. So these are some, I wanted to present some data from a baseline report prior to developing the program, or the parenting program, that really highlighted some other issues at the family or household level that become barriers to really healthy child development. And there's a full report that is very informative, but I just wanted to highlight some things like the access to early child development services, which despite these ECD centers or early child development centers being developed, don't reach the younger children. So among infants aged 0 to 11 months, it was only 3% of the children who attended an ECD program. Among children who were 2 to 3 years old, it was less than 10% of children who attended a development program. So there's clearly a need for interventions. And in terms of learning or support for early learning in the home, the survey found that less than 2% of the households had a children's book in the home. And less than 20% or around 20% of the household had some kind of plaything. As an example, when we go and collect data in these households and we have different surveys to ask about toys and stimulating activities that can be done in the home, some of the items that caregivers might bring when we ask for a plaything is a palm leaf or something that's not actually a toy, but that's what they have available. And it's good that they can come up with something that they can help use to stimulate their child, but one would wish that they had more optimal tools to help children thrive, and that's part of what we do with this program, is to teach them then how to turn this palm leaf into a ball or something that becomes more reminiscent of an actual plaything. House parenting, as I mentioned, also is prevalent in these households, and especially so in the poor households. Among infants, parents reported use of violent discipline in 20% of 20% of the caregivers of young infants that reported use of violent discipline, and in children aged 2 to 3 years old, this figure was even more astonishing or depressing. At 80% of caregivers reported using violent discipline to discipline their child. I also want to remind everyone, I think most people in this room probably are familiar with Rwanda also being a post-conflict setting. So in 1994, there was a horrible genocide that left a lot of physical and mental wounds in the population. It caused interpersonal loss, displacement, trauma, disability, and poverty in large parts of the population. And these war and trauma experiences are known risk factors for poor mental health, both in those who are exposed and in subsequent generations. And the widespread hardship and undernutrition combined with this post-conflict situation in some ways created a double burden that makes it a much more complex environment to work in. And I wanted to bring up this paper, which we wrote recently, which examines how trauma, daily hardships, and poor mental health affects parenting practices among caregivers of young children in Rwanda. So this paper is using data from the Sugiro-Muyango sample, which, again, I'll explain in more detail. But I wanted to bring up this paper here, both to show the vulnerability of the families that we live or work with, as well as to demonstrate an example of the interplay between distal factors and parenting. So the theoretical model that we explored in this publication was this model that trauma and daily hardships, both associated with, the daily hardships are factors or things that are associated with being poor, and I'll give you more details as to what that means. And trauma was assessed at lifetime trauma experiences that often would stem from the genocide experience. And we wanted to explore how trauma and hardships affect caregivers' mental health and whether they influence parenting behaviors through caregivers' mental health and emotion regulation. So we know that hardship and trauma is especially common in post-conflict settings and in poor populations, which is the targeted population of this intervention, the Sugiro-Muyango intervention. We know that poor mental health affects parenting behaviors. There had been previous studies to show this. And we know that poor mental health also is strongly associated with emotional dysregulation. It's kind of like an underlying symptom of many mental health disorders. Emotion regulation is important in parenting. If you have parented a toddler in the age range of the intervention age group, you know that parenting can confront you with situations that feel outside of your control or unreasonable. And it's important to have emotional skills that allow you to sort of cope with those situations and step back. And the wonderful thing about emotion regulation is that it, to some extent, can be targeted in an intervention. It's not very often included in, especially not early child development interventions, but it can be incorporated into a wide range of different types of interventions, both to improve mental health and also to improve parenting. So to do this study, we used data from the Sugiro-Muyango study. So those are parents who had agreed to participate in the cluster randomized trial, but because we used data collected over multiple ways, we had to restrict the sample to control families who did not receive the intervention, because otherwise we would think that the intervention would affect outcomes. So inclusion criteria to participate in the Sugiro-Muyango sample was that they were living in the most extreme level of poverty ranked by the government. So all of the families who are in this sample or in the Sugiro-Muyango intervention, which I will talk about later, all belong to the poorest. It's about the poorest quintile of the population defined by the government. The way that we reach them was that they participate in a social protection system or a program that is offered by the government to try to reduce the burden of living in severe poverty. They had at least one child aged 6 to 36 months and were willing to participate in the study. But exclusion criteria for this specific study, well, for the Sugiyama intervention were that there was a severe crisis in the family, such as psychosis or suicide. They would not be included in neither this study nor the Sugiyama intervention. And then to participate in, or to be part of this sample explored in this analysis. And we also, as I said, excluded families who participated in the intervention. And as I said, I wanted to use this study to also give you some more background to the sample that we're working with the Sugiyama intervention and understand sort of conditions of the context of living in this environment. So we assessed internalizing symptoms and PTSD symptoms as the mental health challenges that might be directly associated with trauma and hardship, might relate to emotion regulation, or could be targeted with emotion regulation strategies, and might affect parenting. And in the sample, we found that 45% screened positive for possible mental health issues related to internalizing symptoms. So internalizing symptoms means depression or anxiety. And PTSD symptoms that were severe enough to be categorized as potential PTSD were observed in almost 20% of the sample. These are much higher rates than what you would expect in a normal population. I hope you all would agree to that. Daily hardships were also very common in this population. So daily hardships are things that might relate to poverty or are particularly prevalent in these post-conflict settings. And you see that almost the entire sample, 92%, reported not having enough money to feel like they were able to live by what they have. So they had this constant chronic stress of being able to find the money to live. Also, many reported the death of a loved one within the last year. Many reported illness in the family, not having a job, loss of income, a lot of stressors. And you also see here, this is so over here we have the cumulative amount of hardships that family or caregivers reported. And some caregivers report multiple hardships, as you see with the high charts for like 20% of the sample reporting 3 hardships, almost 20%, or yeah, almost 20% reporting 4 hardships. So these are a lot of stressors that really can influence your daily functioning. The trauma events that we assessed were drawn from a trauma events list that was used with Rwandan refugees in Uganda. So the traumas that we looked at were having your house destroyed, fleeing, sexual violence, lack of security, or being wounded. So these are events that could relate to the genocide, and they are lifetime experiences of these events. For various reasons, we can't ask directly if those events were directly related to the genocide, but most likely they are. And we see that a third of the sample reported experiencing this lack of security, which is a common PTSD symptom, or these other traumas. So more than, 51% of the sample had experienced at least one trauma, and some had experienced more. I won't go into too much detail about how we assessed emotion regulation, but generally emotion regulation was defined as poor awareness and understanding of emotions and difficulty in registering, understanding, accepting, and coping with emotions. And parenting behaviors were assessed using a tool that was selected because it really, based on qualitative work in Rwanda, seemed to resonate with the way that the Rwandan caregivers conceptualized caregiving. So it was using the scale that reflects warmth in caregiving behaviors, acceptance and rejections behaviors towards the child, and indifference and ignorance of the child, through a lot of different questions that the parents self-report on. And we use this to construct 2 different constructs, low acceptance and high rejection, which are both believed to reflect different aspects of parental warmth and affection towards the child. So first of all, we made different models for caregiver internalizing and trauma, and PTSD. And in this first model, again, this is a complex model, and I'll try just to give you like the takeaways rather than spend too much time going into the details. But we showed that trauma and daily hardships are strongly associated with caregivers internalizing symptoms. So there are some of the risk factors that lead to this high rate of 45% of the sample experiencing internalizing symptoms. And internalizing symptoms in turn was associated with this caregiver warmth construct, rejection behaviors, so that the caregiver was more likely to reject, ignore, or say negative things about the child, experiencing negative emotions towards the child if they were depressed. And there was a very strong association between caregiver internalizing, so internalizing again refers to depression or anxiety, and emotion dysregulation. And emotion dysregulation in the caregivers fully explained the association of caregivers internalizing symptoms on their caregiver behaviors. So this suggests that if you worked with caregivers' emotion regulation in the sample of caregivers who experience these mental health issues, you might be able to improve their parenting behaviors directly by working with emotion regulation as a very targeted mechanism. You can provide coaching and skills in. We saw very similar trends for PTSD symptoms, that PTSD symptoms were very associated with the trauma and hardship experiences. So the more hardships you experience, the more trauma you had experienced in your lifetime, the more likely you were to experience symptoms of PTSD. And PTSD in turn affected warmth in your caregiver behaviors. So both acceptance and rejection behaviors were strongly associated with these symptoms. And most of this association was again explained by dysregulation. So emotional dysregulation in the caregiver was more common if the caregiver had high levels of PTSD, and it explains some of the association with their caregiver behaviors. So what I wanted you to take away from this study, although I realized that it was a brief description, is that the children's immediate social environment, so the caregiver's warmth, affection, is influenced by the caregiver's mental health and the psychological resources that the caregiver has, related to, for instance, depression, anxiety, and PTSD. And but the caregiver's mental health is in turn impacted by their wider environment. So the risk factors for poor mental health are things like daily hardships and trauma. Emotion regulation is an important concept in this context because it seems to be related to both depression, anxiety, and PTSD. It has this impact on parenting. So it is, as I mentioned before, a construct that you can work with in an intervention, and a construct that cuts across different diagnostic categories. So it's experienced by caregivers with these different types of mental health symptoms, and can be incorporated into both direct mental health services as well as parenting programs, which will help to improve parenting in these vulnerable families that experience risks associated with poverty and post-conflict settings. So now to the Suguru-Miyako intervention, which seeks to address all of the risk factors that I've just been talking about. So the Suguru-Miyako intervention is a coaching-based caregiver intervention that is delivered in the home of families to support responsive caregiving and promote ECD and prevent violence in the household. So it can be delivered by trained lay workers. It doesn't have to be a professional trained in psychology or early child development programs, because those are commonly not very available in low income countries. It has 12 sessions of this home visiting program that uses active coaching and teaches standard content on early child development adapted from WHO materials, the Care for Child Development Program, which is a package that the WHO put together to provide materials that are relevant for caregivers to learn about healthy nutrition and hygiene and caregiving practices to support children's development. But outside of this more standard content, the Suguru-Miyako program also recognizes the importance of working with these other more psychosocial resources of the caregiver, so including problem solving, conflict resolution, stress management, stress reduction, emotion regulation, to address these risks of family violence and improve family functioning. And as Sugiyama, the name tells you, build a strong family. The interventionists, as I said, are lay workers. So they are recruited from the local community. They were selected because they've been recommended by local leaders. They have to be literate and interested in child development. They go through an interview to be screened. And then they undergo intense training in the content of the intervention program, as well as the whole concept of coaching. So they do, this training includes role-based and play-based learning in these coaching techniques. And during the delivery of the intervention, once they're trained, there are different ways to quality that the coaches are supervised to make sure that they remain, they keep up with the high quality of the program. So some of these methods for quality control or supervision include in-person supervision just when the program starts, shadowing of the interventionist early on in the program, telephone supervision, and audio recording of sessions. This was, what we did in the trial that I'll be discussing the evidence from. We also have an ongoing trial, but this is shifting a little bit, but we can talk more about that trial in another presentation. So Sugiyama builds on this complex theory of change that really outlined both the risk factors as well as the Sugiyama, the intervention components that were designed to address the risk factors. So it very much used all the data that was available on the challenges to ECD, both the well-known barriers to healthy child development, as well as the more contextual Rwandan challenges that had emerged from that report that I mentioned before with the high rates of violence in the households. So the risk factors that were identified are limited information about children's developmental needs, limited stimulation and learning opportunities, the low rate of children's books and toys in the homes, and low engagement of caregivers in play activities, because caregivers often had a lot of other things to be concerned about with everything else that's going on in their life and all of the other stressors. Lack of future orientation and planning, when you just have to make ends meet that one day, you take things one day at a time, and it can be hard to plan for the future if you're worried about just putting food on the table the following day. Family, social, and economic stress relates to what I just talked about, and risk of family violence. So those are the risk factors that were identified, and then Sugiyama incorporated different components to address these risk factors through active coaching and learning. So there's the teaching on nutrition, health, and hygiene, things that we know are important to child development, to create safe environments, especially if you don't have many resources and have limited means to buy nutritious food. It's important to learn which foods to select and how to prepare them to maintain most of the nutrients, how to avoid that children get sick in environments where there's less modern sanitation. But there's also this coaching and responsive parenting, engagement and play activities with the children, resilience building and coping skills, creating a family narrative, which really speaks to trying to create this future orientation in the families, and tell the story of the family being a strong family and sticking together. Skills in problem solving and navigation of formal resources, linking families with the resources that they have available through the social protection system that is in place in Rwanda, but oftentimes families might not even be aware of it or might not have the resources to connect with these resources that are available. And then skills in emotion regulation, stress management, and other things to reduce violence and improve mental health in these households. So as I said, a key focus point of the intervention is stimulation and play activities that improved children's opportunity to learn. So every session in the program, all of the 12 programs includes a 15-minute play session with active coaching, where they use locally sourced materials in the interaction. So those part of the intervention can also be to help the caregivers create toys if there aren't toys in the home, or teach them how they can use different props in an interaction. And then the coach will, encourage caregivers, mothers and fathers to engage with the child. Father engagement is a big, important component of the program because traditionally fathers are considered the breadwinners in the families, and they don't see it as their role to parent or to take care of a child. That falls on the mother, but the curriculum teaches fathers the importance of being a figure in the child's life, the importance of fathers engaging with children, and how fathers should contribute to the whole family. And one of the ways, so there are different ways that we try to engage fathers. There's the content on the importance of father engagement. Fathers are very much represented in the materials. As you see, these drawings are from the actual materials from the intervention, where fathers are playing with the children and engaging with the children. And then there's flexible scheduling of the program. One thing that often prevents fathers from participating in these kinds of programs is that they might be working when the intervention is taking place, when the interventionist is coming to the home, or when the family goes to a setting to participate in another intervention that's not home-based. And that obviously is a barrier that can be addressed by providing flexible scheduling. But it means that the interventionist, if the father is working during the hours that the interventionist prefers to come, well, then she will have to come later in the evening or on the weekend when the father is available. Some of these caregivers work far away from home and are hard to reach, but it's an important aspect of the program that we make sure to meet the fathers so that they can participate, and anyone in the household can participate in the program. And then another really important part of the program is this violence reduction. That is an addition to sort of the standard ECD or early child development intervention content. But it's this use of active coaching and nonviolent discipline, stress reduction strategies, conflict resolution, and problem solving that really seeks to reduce violence and provide alternative strategies to discipline children and resolve conflicts in the home. As I mentioned, we work with the poorest population in Rwanda, and the way that we reach them is through the social protection program that the government is offering for people who belong to the poorest wealth category. So that has the advantage of being a way to identify and reach the households. It also means that these households already have some resources available that we could hope for synergistic effects if they receive both this as a cash for work program. So it provides caregivers with an opportunity to work and then bring in an income, which hopefully would alleviate some of the stress of living in poverty, that they can expect a stable income and therefore be in a better place to receive a parenting program as well because they have these resources. This is mostly just to mention that most of the data that we've collected took place a couple of years ago now, but we are currently designing a follow-up study with these families. So outside of the data that I'll present to you, we are going back to the families to see how they're doing 3 years after the intervention ended. The caregivers in the sample, this is to give you a feel for who they are. So their age range was 18 to 84. But this is because we work with whoever is defined as the caregiver by themselves. So if that is a grandparent who lives in the household and is actively engaged in the care of the child and is either the primary caregiver because some of these children only live with their grandparents, or is helping a mother, so it's a mother of the child and her mother, then those are the caregivers that we work with, and we encourage everyone in the household to participate. We also have a high rate of single households. We don't discriminate between whether you are a single caregiver household or a multiple caregiver household. And you see here the relationship with the child, that we have different, again, some grandparents, but also a few step-parents, adoptive parents, but mostly biological mothers and fathers. And we have relatively low levels of education, with 23% not having any education, and 50% of the sample having less than primary education. The children are, of course, age range between 6 and 36 months old, and the rate of stunting in this sample is 48%, so almost half of the sample is stunted. We had a developmental screener on which 30% of the children screened positive for a developmental delay or a disability, which was very concerning to us. And in these households, at baseline, almost half of the sample reported use of violent discipline. So I'll probably have to go through some of these findings a little quickly, but I'll try to highlight some of the main findings. So looking at positive and responsive caregiving or parenting, we looked at this in different ways, engaging in stimulating activities and play activities that we know encourage learning in children and provide children with a chance to engage with toys and counting activities and things like that. We had a rating of the home environment. We looked at parent-child interactions to rate the sensitivity of the interaction, both from the mother and the child. And we assessed discipline practices. And we saw that at baseline, this is a count of how many stimulating activities. So there's a standardized list that has been provided by UNICEF for different types of activities that occur globally and are known to support healthy development in children. So these are things like singing and reading and counting, naming things, early opportunities to learn. And we counted the number of activities that caregivers reported having engaged in the last 7 days. And you see an increase here in activities in both groups. The gray bars represent the control sample, but you see how the Seguro-Mianco sample saw a greater increase in these activities. This is the baseline assessment, then we have the post-intervention, and then a 1-year follow-up. So both immediately after the intervention, we see a steep increase in the number of these stimulating activities that caregivers engage in, and we maintain this increase or higher rate of stimulating activities in the households who received the intervention a year after the program ended. This is the rating on a home environment scale that assesses responsivity and attention, acceptance, and variation in activities that the caregiver engages in with the child, as well as learning materials and safety in the home. So the score is not intuitive, but you see an increase in the score in the Seguro-Mianco households that again is maintained over time. And we see increased sensitivity in these parent-child observed observations in the Seguro-Mianco households that is observed both immediately after the intervention and at a 1-year follow-up. So this is an assessment that takes place during a 5-minute interaction between a mother and a child using a book. And it's really rating how in sync the two people are, the mother and the child are during the observation. So the quality of the interaction that they're engaging in. Father engagement was in this study. We're now doing much more to assess this in more detail, but it was assessed using questions about the amount of, or whether they spent time talking to, walking with, or playing with the child daily. And 30% of the households, whether intervention or control, reported the father was engaging in these things with the child before the intervention, but this the number increased to 42% of fathers engaging in these types of activities with the child in the families that received the intervention. Harsh discipline, you see a steep decrease in the Seguro-Mianco households. So whereas the control family have this count of 1, which is a rating or a summative score of different types of harsh discipline methods like slapping, spanking, shouting, calling hurtful names. So on average, the families who, or at baseline, on average, everyone, the households on average reported one of these harmful discipline strategies, but this decreased in the intervention households after, both immediately after the intervention and also a year after. In terms of the nutrition of the children, we didn't see, as I'll show you, any changes in children's growth, but we did see changes in caregivers' behaviors to support growth. So that might have a longer-term impact on their growth that we can't detect immediately, but we saw that families who participated in the program provided a more diverse diet to their children. This is assessed as a count of the different types of food categories that the children ate in the past month, and you see that children who participated in the program had a more diverse diet with a higher score, so meaning more different types of food. But as I said, we didn't see any changes in child growth. All of these bars are negative, which means that they, based on WHO standards, scored below the expected height or weight for their age group, but we didn't see changes in it related to the intervention. We did see changes in caregivers' behaviors when children were sick, though. Caregivers were much more likely to, so this is the percentage of caregivers who would seek care if a child got sick. And we did see a significant increase in the families who participated in the program who would seek care if a child had symptoms of diarrhea or fever. So take them to appropriate care rather than rely on the local communities and non-traditional medical approaches. Child development, we assessed across different domains of development using the Ages and Stages questionnaire, which is a parent-reported and observation measure. It encourages parents to report on the child, and some of these things are things that the caregiver can play out with the child during the assessment. And you see that it's again a standardized score. So when we see negative scores, it's because that the child would be scoring lower than what is expected for their age range. But what we see is, I find it less intuitive to see when the bars go this way, but I hope you can still see that there is an improvement in the scores in the children who participated in the program, because it becomes their behavior becomes more normal. So you see across domains of gross motor, personal, social development, communication, and problem solving, you see better outcomes in the children who participated in the program, and more so, more so in the children who participated in the program compared with the control families. We didn't see any improvements in children's outcomes on fine motor, though, which, there could be different reasons for it, but I think mostly we're just glad that we did see improvements in child outcomes and other outcomes. Well-being, in terms of the caregiver's well-being, we also saw, just like we saw a decrease in the use of violent discipline, we saw a decrease in intimate partner violence, which we think again relate to this use of stress regulation, conflict resolution strategies that are taught through the Sugiyama program. So this is activities reported by mothers that relate to both physical, sexual abuse, victimization. And although the program doesn't directly work with caregivers' mental health, that is a potential add-on to the program. That's not part of the program outside of the stress regulation and coping skills that are currently in the curriculum. But we did still see an increase in positive mental health, or a decrease in symptoms of depression and anxiety. So this is a mean score on the Hopkins symptom checklist, which has a widely used cutoff of 1.75 as a possible a parent screening positive for possible depression or anxiety. And we see that at baseline, that's the mean score of the sample is right around this cutoff. And we know that from the previous study that I showed you that 45% screen positive for depression or anxiety. But this mean score, so the symptom score was lower at later time points, which means that fewer caregivers reported multiple symptoms of mental health problems related to depression and anxiety. This positive impact of the intervention was observed immediately after the intervention, but was not sustained over time, which is maybe an area of improvement if there was more explicit focus on mental health in these caregivers in the program, or more inclusion of follow-up in booster sessions with the caregivers to help them maintain these effects. So outside, I didn't mention this when I discussed the program, but outside of the 12 modules, we also go back to the families after 3 and 6 months to sort of remind them of the curriculum. which is part of how we are able to maintain these effects. But now we'll see when we come back 3 years after the intervention ended, how well they still are able, when we haven't intervened with them at all for such a long time, how able they are to maintain all the changes. So if you're interested in more details about these findings, we have 2 publications out that discuss all of this that I can share if you reach out to me, or you can find by looking up the publications of the lab. With all of this data, I think some of the most important key takeaways that people remember are some of the citations. So we have outside of all the quantitative data, we have rich qualitative data as well. Some of these citations really, or quotes from caregivers who participated in the program, also really speak to the effect of the program better than the data could, or bar charts could in their own. So I highlighted some of them in color. If we look at the one in the middle in purple, this is a mother who said that Seguro Myango boosted my child's communication, how to behave while having a conflict with another, and when the child is sick, I immediately go to the health center. Before Seguro Myango, I used to give them traditional herbal medicine. It also builds hope for the future. So she really mentions a lot of the different components that Seguro Myango actively tries to incorporate into the program. The green quote is also from a mother who says that I'm proud that everyone is saying my child is sharp due to Seguro Myango teachings. So she feels that it has this impact on children's cognitive development, which is something that caregivers maybe didn't pay so much attention to before the program, but through the program they really learn about the importance of children's cognitive abilities and outcomes, and she sees that her child is in a better place and has better opportunities after the program, and she's proud of that. We have a quote from a father in more pinkish purple, where he said, we normally have stress caused by our daily hardships, but through Seguro Myango we have learned how to manage stress caused by poverty. Personally now, I wouldn't hit my wife or my child when I'm stressed. Either I go look for a friend and talk to them instead of shouting at home. So these are some of the conflict resolution, emotion regulation strategies that are taught through the program. So we have a lot of different ongoing work within this project and the Seguro Myango intervention. We have further analyses to better understand how we're achieving these positive outcomes in the families. So in order to improve the program, in order to understand what are the most important aspects of the intervention, what are the links between the changes we see in caregivers' behaviors and the child outcomes. To understand all of these processes, we're engaging in sort of mechanistic models. We also are designing a follow-up study, as I said, to the cluster randomized trial. So we'll be going back to the families 3 years after the intervention ended to look at some of the same outcomes to see if we sustain effects still, but also look at new outcomes because the children are now older. So they're getting to just around preschool and school, early school age. And we can look at school readiness outcomes, emotion regulation, which is harder to do with younger children, and behavioral problems to see associations between parenting programs and children's abilities to regulate their own emotions. And we have an add-on study incorporated in this follow-up study where we'll also be looking at not only the children who participated or were eligible for the program, but also their siblings, their younger siblings and older siblings, to see if they benefited from a parenting intervention. As I said, the intervention really works with the entire family system. And also encourages participation of siblings of the children who were in the study. Obviously, it works with the caregivers, so we hope that the program also benefits other members of the families outside of the children who were eligible. Then we have this large scale-up study that is ongoing right now. Families are actively receiving Seguro Myango interventions in 3 different districts in Rwanda, and the aim of this study was that now we'd establish the effectiveness of the study through the evidence that I just presented to deliver this intervention to 10,000 households in Rwanda to help improve child development in this large population of children and families. It has an embedded effectiveness study. It has implementation science studies incorporated that we'll be excited to share findings from. This was just an example of a mechanistic model, but I won't go into detail, so I'll just show funders and partners who've contributed to this work and made it possible to not only do the 1,000 household trial that I presented evidence from, but also now do the 10,000 household scale-up study. So thank you for your patience with me. Thank you for listening. Reach out if you want to know more about the program, want to know more about our publications, read our publications. And then I also just wanted to advertise that because of all the ongoing work and how we continue to expand our portfolio of work in the RPCA, the research program on children in adversity, we're recruiting for several positions that either might be of interest to you or might be of interest to someone you know. So I just wanted to mention that.